Hey, good evening, everyone. Welcome to another episode of Back to Basics. Very nice to see everyone on tonight. I'm Dr. Vivian Asamoah. I am a gastroenterologist and a functional medicine provider here in Katy, Texas. I am going to be talking tonight about bloating, which is a common problem for a lot of gastroenterologists. And this is probably one of the reasons why I started looking at nutrition and food as medicine, as well as functional medicine or integrative medicine, whatever you want to call it. Because after a couple of years, even in fellowship and in practice, I noticed that I wasn't able to help a certain percentage of my patients, and it's still difficult, right? These are patients with chronic gut symptoms who, suffer from maybe chronic bloating, especially bloating, diarrhea, nausea, vomiting, weight loss, just an extreme fatigue, right? And they have been labeled as IBS for the most part, which is known as irritable bowel syndrome. And that diagnosis is, I don't like it at all. Because it doesn't mean anything. And in the past, irritable bowel syndrome had been associated with you would correlate it with a woman, probably in their 20s, 30s, 40s, who was a little anxious, and it was believed to be psychosomatic. Like it was a thing of the mind, like the people were just kind of stressed out or overly anxious. And that diagnosis, that term is something that I think, paternal medicine or paternal physicians had always used to label a lot of women. It kind of was like fibromyalgia. We didn't understand it very well, so we gave it a label. And so IBS was that label for GI, or is that label for GI. And I decided that I wanted to be a GI doc who tried to go a little bit deeper as far as I could. Not saying that I find success with every patient, not saying that I find the solutions with every patient. And some of the reasons for that is because we either just don't know, medicine has not developed it, or I don't know, right? Like I don't know everything, right? There's some diagnoses that may still escape me or are still elusive or are still really not described in the literature, or you've just never come across it. So you just never think about it, right? And that's why you have super specialists. But anyway, I'm rambling on because this is a topic that I'm extremely passionate about. It then, because I started looking a bit deeper for my patients, and as I started looking, I realized that how important nutrition was, right? And then I realized how important not just nutrition was, but the whole environment around us and how much it can impact our GI tract. And then, about a decade ago or more, the whole Human Genome Project thing came out, the gut microbiome. We just discovered how amazing the gut microbiome really is and how important it is to us. And then it just took off from there. I just developed this deep passion, deep interest to help my patients with chronic gut issues because I found that a lot of them did have a diagnosis or were mislabeled. So again, I'm rambling, guys, but this is just to present today's topic, which is why am I bloated? So just that classic patient that presents to me with bloating. I want to welcome everyone on. If you guys have questions, I will try and answer each and every one of them. I'm so glad to see you guys on tonight. It's 6:36. I know some of you are driving home. Some of you are already at home, maybe making that wholesome dinner. So if you're catching this on the replay, please put in a whoop whoop. Let me know that you're catching this on the replay. I kind of want to see how many people watch this on the replay. But tonight we are going to be diving into a clinical case just to explain just some simple scenarios that I see as a functional gastroenterologist and how I treat patients, and just understanding a little bit more what you may not be hearing from other gastroenterologists, or maybe what you may be hearing too much of, but without enough fact from other holistic providers, just other holistic providers out there. So I did present a PowerPoint presentation, and I hope nobody has put in a whoop whoop. Nobody put in a, hey, Dr. V. Nobody put, hey, guys. I see some people out there. So put in a comment so I know that my whole system here is working, because I'm about to flip onto my PowerPoint presentation, which will be brief. And then I'll just kind of talk about what I know, okay? All right, I'm gonna try and flip over and do like a share thing. Hold on, let me see if this works. share my screen. Share. You guys will see everything that I'm looking at. Can you see me? All right, I hope you guys can still see me. I'm gonna check on my other screen that it's working. That it is working. Yes, it is working. Okay, great. So I wanted to talk about a patient. So I put some slides together because I always think images are better. And our topic today is small intestinal bacterial overgrowth, otherwise known as SIBO, right? And very often we'll hear our patients come in with a lot of symptoms, but some of them, the biggest complaint usually is, why am I so bloated? I feel 6 months pregnant. You know, as soon as I eat something, like I'm so bloated, what is going on? And there are a lot of reasons to have bloating. So please, not everyone with bloating has SIBO. There are a whole bunch of other reasons to have bloating condition or bloating issue, right? We'll talk about that in a little bit more detail, but I am going to focus on SIBO. Okay, so I want to talk about a patient I saw. I have changed the names. I have changed a lot of things, so nobody recognizes this patient, but she is a true patient of mine, and we'll call her Casey. And Casey came in with a 3-month history of abdominal pain, nausea, fullness, bloating, but she was having regular bowel movements, but she was cramping after meals. She was having heartburn. She just felt like her gut was off. And she'd seen another GI doctor who had put her on that PPI, the pantoprazole, 40 milligrams once a day. She'd been taking that for a couple months. It wasn't really resolving a lot of her symptoms. Definitely wasn't helping with the bloating. In her medical history, sorry, Casey's 38, when I forgot to add that. In her medical history, she had anxiety. She had a history of endometriosis, had some laparoscopic treatments for that to remove scar tissue. But other than that, was doing relatively well. She was hoping to get pregnant. So she was dealing with some fertility issues and she was working with her gynecologist on that. Her mom had celiac disease. So there's a history there of autoimmune disease related to a food sensitivity. She didn't smoke. She drank a little bit. And she'd seen, of course, this prior GI doc who told her she had GERD and IBS. And she went and looked up IBS and she was like, I never had this before, because IBS also comes with, we call it in GI, we have a criteria, we use different criteria, and this is defined as a functional gut disorder in a Rome 4 criterion. You have to have had like abdominal pain, changes in your bowel habits for probably about 6 months before you can even give it that diagnosis. So one red flag is, she never had this before, so why did it all of a sudden at age 38, why is she showing up with IBS? So I kind of looked at her tests and did some additional tests just to make sure, as a gastroenterologist, first and foremost, I want to make sure that there's nothing that I can treat easily that's reversible, right? But at this point, we're looking at Casey, and Casey's been dealing with these symptoms for about 3 to 4 months already. She had an endoscopy, right? That makes sense. You want to kind of look and make sure there's no gastritis, no bacteria in the stomach, no ulcers in the stomach, right? She had an ultrasound to make sure there were no gallstones. And then she even went to have a CT scan to look at her pancreas and her other organs, and that was all fine. That was all good. So that was a decent workup. And so when she came to see me, I started talking about, well, could this be SIBO? So let me go back 1 second, guys. In a young lady, age 38, who has bloating issues, it's really important that this is still evaluated by a doctor, right? It's still evaluated by, you guys call it conventional doctor. If you find someone who has a more holistic or integrative approach, that's great. But you don't know what you don't know. So if you can't think of a broad differential that this person may have, you might just say it's SIBO, or just say it's a food allergy, and it may not be. So in a young woman at the age of 38, it's still important to get a full evaluation like she did, right? Blood work was done. A diagnosis of bloating, you still want to think of things like ovarian cyst, ovarian tumors, right? Ovarian cancer, one of the first diagnoses is bloating, right? You want to think of Crohn's disease, ulcerative colitis. Crohn sometimes will give you bloating and pain, but you don't necessarily have diarrhea. So you want to look at her meds, make sure she's not taking anything that's contributing. So there are you want to look at hormones, right? You want to look at her thyroid. You want to ask other questions about fatigue, hair loss, dry skin, mood swings. You want to at least be able to work with someone who can order labs, interpret the labs, and then define next steps, right? But a lot of that had already happened for Casey. And so I started thinking instinctively, because she had had a pretty good GYN evaluation of bacterial overgrowth. And bacterial overgrowth is important whenever that diagnosis of irritable bowel syndrome comes into play, because at this point in time, there are probably over 32 studies, right, with over 3,000 patients that have shown that about 30 to 40% of patients diagnosed as irritable bowel syndrome actually have SIBO. This is a very important fact, to a point where the American Gastroenterology Association has now described in its compendium sort of like best practices for SIBO. It is a recognized diagnosis, it continues to evolve, and it's one that we have to pay attention to. So if you go see your gastroenterologist or whoever that may be, and they say you have IBS, and they shoo you out of the room, and they don't question a possible diagnosis of a microbiome disturbance, you need to find another doc, because this is described in the literature as of data as recently as May 2021. Okay, so we understand what SIBO is. It is not an acute infection, right? It is a chronic gut infection. We call it more a dysbiosis, and dysbiosis just means there's an imbalance in the ecosystem of the GI tract, right? And normally, the GI tract is divided into two groups. The upper GI, which starts from mouth, goes all the way down to the food pipe, the stomach, the first portion of the small bowel, and then the lower GI, right, which is really the large colon, right? And the upper GI tract, including the 20 feet of small bowel, is considered to be fairly sterile. It is clean. All it's supposed to do is digest, absorb, maintain its barrier, support the immune system, release, the fatty acids, the amino acids, and the monosaccharides, the sugars, so that our body can utilize them, right? And once it's taken up what it needs into the bloodstream, that waste then passes into the colon. And with that waste comes some fermentation from bacteria that's normally in the colon. That's where it's supposed to be. So in our GI tract, there are trillions of bacteria, but most of them are actually, I would say 90% of the bacteria is actually located in the colon, right? And when we start noticing that there's bacteria, when we start talking about SIBO, we're talking about small intestinal bacterial overgrowth. There is overgrowth in an area that was supposed to be sterile, is now overgrown with bacteria. And it can even be parasites. It can also be viruses, because in that microbiome, it's not just bacteria there. You have prokaryotes. So we're going back to basic science now. Microbiology lab, guys, remember? 9th grade, maybe 7th grade for some. So prokaryotes, parasites, bacteria, virus, and all their genetic makeup, right, is what is in a microbiome. So yeast, I forgot yeast. Yes, we can't forget yeast, because yeast is a big part of this. So these are things we don't see in the small intestine. And when we start detecting them in the small intestine, imagine, it changes the entire function of the small bowel. So the small bowel that's supposed to digest can't do so well. It's supposed to absorb, it cannot do so well. It's supposed to protect the immune system. Immune system is off. Endocrine system, make neurotransmitters from its amino acids, not happening anymore. That's why we talk about that brain-gut axis. Patients start becoming more anxious, sad, just feeling off, and they get really tired. So when the gut microbiome is affected, when there's dysbiosis and the small intestine can't do its job, that's what leads to the symptoms that patients have, right? The malnutrition, malabsorption, the vomiting, diarrhea, the bloating, the nausea, the joint pain, because you've now developed leaky gut, right? And microbial particles are seeping through that membrane, that intestinal wall, right? And going to all parts of the body through the bloodstream. The first part of the body being the joints. The second part that they really, drive to, or the vascular supply takes them to, is the brain. So a lot of brain fog in patients with bacterial overgrowth. And the third is the skin. And so I'm highlighting eczema. The skin is one where we see a lot of symptoms. So patients with SIBO can have an array of systemic symptoms because although the issue is the gut, that gut is responsible for maintaining that barrier, providing 70% of the immunity in our entire body. And that brain axis connection is so important. It does affect the whole body from head to toe. And that's why SIBO is so important. And that's why SIBO can be picked up in any specialty of medicine, right? So we know that there are two types of SIBO. Well, there are three types of SIBO, but we'll talk about that in more detail. But small intestinal bacterial overgrowth symptoms, there's another type of bacterial overgrowth called intestinal methanogenic overgrowth. When we actually have bacteria in our small bowel, the bacteria ferment food and release gases. And there are three types of gases that they release: hydrogen, methane, and hydrogen sulfide. Now, I just discovered this. If you have one of those tests, and we'll talk about the SIBO test that's positive, it truly is positive because there's no other cell in our body that can release gas. It has to be a bacteria in the wrong spot, right, in the small intestine. And when they actually come in contact with food, especially carbs, they love carbs, they ferment, release the hydrogen, methane, or hydrogen sulfide. That hydrogen, as the gas, as it's light, seeps through into the vessels, right, into the bloodstream. And the biggest area of blood supply is actually where? In the lungs, right? And so that it seeps into the alveoli of the lungs, and you breathe that out. And that's how we can detect from gut through bloodstream to lungs to breath, the breath test. That's how we can detect what type of bacterial overgrowth it is. And so we usually will talk about hydrogen and hydrogen sulfide, but hydrogen is predominant. I won't even talk about hydrogen sulfide today as the major types. These come from bacteria. We even know that it comes from specific types of bacteria, strains of bacteria. And hydrogen sulfides, hydrogen SIBO will cause bloating, belching, sometimes diarrhea, less often constipation, malnutrition, nausea, and this is where it's termed IBS, right? Now, intestinal methanogenic, this is the one that will release more methane. This is caused by a type of prokaryote called archaea. These are specific strains of microorganisms known as methanogenic strains, and they usually cause abdominal pain, bloating, constipation. So that's the difference here, right? Skin issues, leaky gut, malnutrition, and some of the other symptoms. So it's just kind of different types of bacteria will give you different types of gases, and that kind of helps with treatment. So SIBO is so important because we said it can cause a lot of major health problems because it affects the whole body. And the longer you have SIBO for, the more chronic issues you develop because you develop leaky gut. And if it's not treated, you can go on to developing chronic skin conditions, autoimmune conditions, right, that lead to other complications and other problems. So this is an example of the lactulose breath test that we actually did for Casey. And it's a kit, guys, that has like all these tubes in it, and you have to drink a substrate that's a sugary medication called lactulose. And we use that substrate because it's like the perfect form of a carbohydrate that is going to get fermented by bacteria if bacteria is in there, right? And so the patient leaves with this kit. There's several companies that do this. Now, let's just talk logistics a little bit. The test is, a patient of mine today told me that it's considered experimental. And I was so surprised to hear that because I was like, wow, we've been studying SIBO and doing all this for a while. So I think it's the same thing. Insurance is usually lags far behind in the research, but they still want to dictate what they're going to cover and what they're not going to cover. So for a lot of patients, sometimes they have to pay this out of pocket, costs about $250 to $300. And for some, they don't. So there's some insurance companies, it really depends. But when you take the kid home, I usually just say, go watch the video, because there are instructions about how to prep yourself for the test 12 hours before. They don't want you eating any carbs, because they want to make sure that the carb that you first ingest is really from the substrate, that lactulose, that sugary beverage. Yeah. So you make sure you don't eat anything for 12 hours. Make sure you've got your Netflix or your Hulu or Roku, whatever, set up, because you're going to be home for 3 hours straight. And you're going to because you have to drink this liquid and blow in this tube every 20 minutes, I think. Yes. For 3 hours. And the reason why we do this over time is because we're kind of looking at where we start seeing the increase in the gas production. If it starts at 20, 30 minutes, if you drink a liquid, it's probably in the first portion of your small intestine, right after the stomach, around that time. But if you blow in around 60, 70 minutes, you're closer to the middle, near the end of your small intestine. So we know that fermentation and that hydrogen, the gas release, is coming from the upper part, right? The small bowel. And the criteria, according to the American Gastro Association, is that at 90 minutes, it's now in the colon. So we expect to see a rise in the hydrogen and the gases, because that's where we know, guys, that there's bacteria, right? So with Casey, and Casey is a made-up patient. Okay, she's a real patient, but I'm just really changing her name so you guys can understand, and presenting her case so you understand the whole picture. When we get the results, this is how the SIBO results. It's a part of how the SIBO results come in. The first part patients will really look at is be like, oh, what did it say? And it says indicative of small intestinal bacterial overgrowth. So yes, you have SIBO. But then I dig a little bit deeper and I say, well, what type of SIBO is it? And if you guys can't see this, very well, her hydrogen is the one that's actually really high. It's supposed to be less than 30 and she's already around 55. The rest are fine. But then I dig in even further and I look at the times, the different bottles every 20 minutes, and I want to see if this is something happening more early on in the small intestine or later in the small intestine. But that kind of helps me figure out maybe what's the cause of this, what's really going on, okay? And this is just a graph looking at the different types of SIBO and the different gas increase, right? I won't go too nerdy on this. I will just move on. So why are some people going to get SIBO and others are not? How come some people have IBS and others don't? What predisposes someone to getting SIBO, right? So this is based on pure data. And I don't know what's going to happen in the future, but at least this helps guide us when we're trying to identify someone who has bacterial overgrowth. Do they even have the risk factors? Is there a cause, right? So just being female doesn't mean you're gonna, the female gender doesn't automatically predispose you. This just means we see it more so in women. And probably because more women have had hysterectomies and gallbladder removals and, those kind of things, or endometriosis like Casey had, and had surgeries and has scar tissue that's pinching on the small bowels and impeding flow. Older people, medications like PPIs, and remember Casey was on that pantoprazole, so this is all that proton pump inhibitor, and we talked so much about it. There's so much to share. It really causes low stomach acid, and low stomach acid is a predisposing factor for SIBO. People who have like chronic GI issues, like functional bowel issues, Crohn's disease, IBS, we don't even know if it's predisposing, but we think a lot of IBS is actually SIBO, right? People who have diverticuli, autoimmune disease like systemic sclerosis, definitely abdominal surgery just because of what we discussed in the scar tissue in the small bowel, around the colon, pinching and impeding flow. It's almost like you have stagnant pools or puddles, stagnant lakes sitting there. And what's going to happen? It's going to breed, it's going to ferment. You're going to get bacteria and fungi. Other causes, heart disease, diabetes, hypothyroidism, autoimmune disease, pancreatitis, especially chronic pancreatitis if you had gallbladder disease. I'm bringing up Parkinson's and Alzheimer's. This is so important because I don't know if you guys remember one of my gut over it videos, and this will be a great time to bring that back, where I talked about Joy Milne. And Joy Milne, I digress, but there's a lot to share, guys. This really connected the dots for me. Joy Milne is a nurse. She's still alive. And she is like one of 200 people in the world who has this like super olfactory sense. She can smell anything. And she can actually, when she smells people's breath, she can tell if they're sick. She can actually tell what kind of sickness they have. She's actually been able to distinguish between Parkinson's, Alzheimer's, and cancer. So this really tells us, this is amazing. This really tells us that when there is something off in the body, there's dysbiosis, there's probably SIBO. And it's possible that there's certain types of bacterial or microorganism strains that are more associated with maybe brain pathologies, brain diseases like Parkinson's and Alzheimer's, or breast cancer or cancer diagnosis. And Joy Milne is being used in research studies all over the world. I think she's Scottish, but she figured this out. She figured out this gift because her husband, who was a doctor, his breath started changing when they were about 20 years into the relationship. I mean, she said the breath was just so different. So almost like, she said, almost like mold. And it took her, she noticed the change in the breath, and she noticed a change in his mood. He was like depressed and slow and sluggish. And between the time she noticed this difference in the breath and the time of his actual diagnosis of Parkinson's disease, it was a 5-year gap, guys. For 5 years, she knew something was off, but she didn't know it was Parkinson's. So he had early Parkinson's. What's more amazing about the story is that she started smelling this breath in other people. And every time she looked into it, that person had some kind of disease like Parkinson's or Alzheimer's. And so she self-reported to the medical board and said, well, I'm noticing something. And from there it took off. And they did a huge study with Joy Milne with like 100 breaths in a tube or something like that. And she made the diagnosis 92% of the time just by smelling the breath that this person had either cancer, Parkinson's, or Alzheimer's. Amazing. But this goes back to our whole concept of that breath test that tells you that there's some dysbiosis going on that can reveal actual pathology. So this was an amazing one. I'll never forget that about her story. Now, bacterial overgrowth comes with its complications, right? Because as we said, the small intestine is not doing its job anymore. It can't break down the macronutrients like protein, fats, and carbohydrates. It can't break down the micronutrients. So you have a micronutrient deficiency as well. It's not absorbing vitamin D, vitamin E, K, and A. We see severe vitamin B12 deficiency. So if your B12 is low, we have to start thinking about malabsorption, right? And so along with looking at other things like, are you not eating enough red meat? And are you taking a medication that could be affecting? You have to think about SIBO and test that patient for SIBO, right? That would be an easy fix. But what happens too is that the bacteria or the pathogens start causing a lot of inflammation and causing a destruction in the lining, that barrier of the small bowel, and cause leaky gut, okay? These are some other complications. So with Casey, we noticed that she had a low vitamin D. She was like at 10. Her B12 was super low, like at 100. So we had to actually put her on B12 shots. Her iron was low. Her omega fatty acids were low. So we continued with a detailed stool test. And some of you guys may have done this test with me already in clinic or done it with other providers. But this is a test that kind of looks at the microbiome in your entire GI tract. Unfortunately, as you are actually analyzing stool, you're analyzing everything in the gut from mouth to anus, right? It also includes the colon. So you can't really make a full diagnosis of SIBO, of the small bowel based on stool testing, but it gives you a good sense of what's in abundance or what is deficient in terms of the microbiome. It also gives us a lot of information about Giardia, if there's a parasite, because in Casey, we did identify Giardia. So she had a positive Giardia test. And then we saw that her gut immunity was extremely weak. And then I bolded out and all capped the word zonulin, because I think this is a word you guys should all know. Being on natural gut relief, you guys are going to know SIBO like this. But zonulin is sort of like the little, the bridges that hold the intestinal membrane together. And when we start seeing zonulin in a comprehensive stool panel, meaning it's coming out in stool, that means it's broken off and you have leaky gut. And zonulin, it's no longer doing its job and holding things together. And from a functional medicine standpoint, we go even deeper. We go into the detailed micronutrient panel. We look at every vitamin, every trace element. We look at organic acids, products that are released from bacterial breakdown, amino acid breakdown, your neurotransmitters, to really see how much the SIBO has impacted your entire being. So we don't just fix the gut and just give you a couple of vitamins, but we go all the way to try and identify deficiencies and root cause. So we come back to our 5R, to heal SIBO, we come back to our 5R protocol for a lot of things in GI, especially from a functional GI standpoint. And if you guys have done the elimination diet, we talk about this all the time. Remove, replace, re-inoculate, repair, and rebalance, right? So removing the stressors, replacing the nutrients that are missing, the vitamins, the stomach acid, you guys, we spoke about when you're on PPIs, your stomach acid goes low. Re-inoculating with prebiotics and probiotics, repairing. I stole this from online, guys. They put an E after repair. That is so wrong. Anyway, repairing the intestinal wall and then rebalancing. This part is so important. Rebalancing your lifestyle. And we'll talk about that in more detail. So this isn't Casey, but she kind of looks like Casey. Casey was really beautiful. And what we did for her is right away start with the remove. We put her on the antibiotic, the one antibiotic that has been shown to have at least 60 to 70% efficacy for SIBO if it is hydrogen dominant, which is Xifaxan. And that's rifaximin. And it's an old school medication. We like it because it works against different types of pathogens, you know, whether it's gram-negative, gram-positive, anyway, different types of pathogens and bacteria. And we don't like it because somehow the company has a patent on it and it's very expensive. So we have to like submit coupons and do all these things to get it for our patients, but we try. By removing, you also want to remove carbs, right? You want to remove the food that is feeding the SIBO. So we put our patients on what we call the low FODMAP diet. And we've talked about this in our previous Back to Basics episodes. So if you guys want to listen to that, let me know. I can share that. But basically, it's getting rid of foods that will release a lot of gas, right? We restore by giving sometimes hydrochloric acid. We give back acid so that the gut digestive juices can work. We give digestive enzymes. We give bile acids if they've got their gallbladder removed or if there's a need. We want to repair the gut with, I should have flipped it actually, repair the gut though with things that we know science has shown. And I did all the research on this because I wrote a paper on repairing the gut. And these amino acids and essential trace elements have been studied and shown to repair the gut. I think the only thing we probably don't do really well in practice, whether it's holistic or conventional, is we probably don't give our patients enough dosing. We're a little bit worried. Like glutamine, we usually give patients 5 grams. But if you look at the research, it says like, you know, the studies were done with like 14 grams, right? So repairing the gut with zinc, carnosine, and then the slippery elm, aloe, okra, those mucilaginous products that help. Re-inoculating with the right probiotics, because you want to starve, but then you also want to nurture, you want to feed, right? So giving the right probiotics and prebiotic-rich foods. But the biggest part of this is rebalancing. Because one area that I've always not been successful in fully helping a patient is, you know, with the rifaximin, we'll see, wow, it's much better in a lot of people if the diagnosis is right. And you're adding the digestive enzymes. And this is all for like, rifaximin is just for 2 weeks, guys. The digestive enzymes you can add for like a month or so. But when it comes to rebalancing, there's only so much I can do, right? This is something that has to come from the patient internally to recognize and identify their stressors, because we mentioned that SIBO and the whole small intestinal bacterial tract, there was a huge gut-brain connection, and there's a huge, what we call the HPA axis, like the cortisol connection with the brain, with the gut. And so if someone is anxious or someone is in that constant fight or flight response, and there's a lot of stuff going on and they haven't really taken the time to do introspection, understand where their anxiety or stress or depression is coming from, and actually start tackling it themselves, or either getting the supportive care through counseling, talk therapy, meditation, it doesn't get better. If the situation that they're in is causing a lot of stress and that is feeding onto the gut issue, there's no amount of antibiotic glue supplement that's going to fix that. And very often that's the most difficult part with patients, when, they're like, just give me the medication, just fix me. Sometimes our patients will come to us wanting a functional medicine approach. And then when you start talking about, stress relief, introspection, mind, body, soul, mind, body, energy, really, really, really understanding and processing and talking about what's going on, they block. They're like, just give me the medication. And I said, well, that's the difference with functional medicine. We talk about that, the whole body, the whole person, the mind, body, soul. We don't just write a prescription and give it to you. So yes, there are providers who are completely traditional, conservative medicine, very, academic in the way they've trained. But there are also patients, even who are seeking functional medicine, who are extremely conventional in their approach with health and how their relationship with their provider. And they just, they feel like, well, I'm paying for this, and so just give me the thing and just fix it. But when it comes to that deeper work that we sometimes have no control over, it's tough. But Casey did great. She identified her stressors, and some of it had to do with the fertility issues. And she was battling with that because of the endometriosis. That was causing stress internally, although her partner was not really stressed out about it. But she started letting go a little bit, and she started meditating. And that really helped her overall process. I got her into physical therapy for abdominal massage, and I think she loved that. She had a lot of scar tissue. I think that was one of her risk factors for SIBO. She had a lot of scar tissue, and so the massage therapy, I think we sent her to, I can't remember, well, one of the massage groups we had done, the physical therapy groups, we had interviewed on Back to Basics, and she enjoyed it. And I saw her about 2 weeks ago, and she said, Dr. V, I am 90% better. 90% for me is a win. It's a win. So that was Casey's journey, and that was a little bit about SIBO. I know it's a lot. I'm going to try and go back to my own screen. I don't know if you guys can see me. I'm trying. Yes, I'm back. So I know I said a lot, and there's even more information to share, because I'm in the midst of preparing a big talk about SIBO and yeast overgrowth and parasites. Oh, I forgot, we did treat Casey's parasite, the Giardia. She thought she got this from swimming in some lake somewhere in East Texas, but she got better. So this was a lot of information. I shared my heart with you guys. Poured my soul to you guys, because I think this is SIBO is one of the main reasons I jumped into integrative and functional medicine. I wanted to offer more than what my traditional, albeit wonderful fellowship at Hopkins taught me, but I felt like I wasn't getting great relief with my patients from that standpoint. I continue to learn every day, because we don't know everything about SIBO. I think we're still discovering, right? We don't know everything about SIBO. We know there's yeast overgrowth as well. And so we're trying to figure out how to tackle yeast overgrowth. And I have quite a few patients with yeast overgrowth. And those are some of my most difficult patients, because you realize you have to put them on yeast therapy for anti-yeast medication for a long time. And this past weekend, I was preparing the yeast overgrowth section for this big presentation I'm going to do. And There were like 2 studies. That's it. There's very, very little in the medical literature. So personally, I would love to get involved in more research, because I think that's the only way we're going to be able to really get quality evidence and make this kind of information accessible and like accepted by all gastroenterologists and all physicians, so they can treat. Patients don't spend so much time in pain and discomfort, like months and months and years for some, to a point where now their hair is falling off and they have such bad malabsorption, and their body is so deficient in nutrients, and they can get it taken care of really quickly, right? So I that's another thing I'd love to do, is teach other GIs how to incorporate this into practice. But before I do so, I'm relying on you guys to teach me how to do it right. And so I have to keep reading, and I have to keep getting feedback from you guys. And it's not always easy. We have cases of refractory SIBO, the SIBO that never goes away. That's another story for another day. Maybe we'll talk about refractory SIBO another time. But I hope this was useful. I see some comments. I don't see a lot of questions. It says we see you, but thank you guys for joining me tonight. Put your comments and questions in. I'll be happy to answer. If you guys want to learn more about the comprehensive stool testing, about the SIBO test, if you're thinking of someone you know who sounds like they may have SIBO, very often they have autoimmune diseases as well. Traumatic brain injury has been associated with SIBO. I mean, there's just so much. I think the learning is just, the sky is, is the limit. We're just learning so much. If you know anyone, let them connect with me. Our 12-week program is our functional gastro program. It's the signature functional gastro program, where we work with patients who have chronic GI illnesses, who've gone through a lot of conventional testing, endoscopy, CT, whatnot, who have not found any resolution. We try to help them in the most natural way to restore their gut and restore a healthy relationship with food. And seeing a doctor, a DO, whatever, is important. Seeing a provider who knows when to refer you to the right specialist is really important. Because in our functional gastro program, we have met some of our patients who actually had seen multiple holistic providers or functional medicine providers or multiple GI doctors and not had a diagnosis. But when we got the records and we analyzed the records and we evaluated the data, I would say at least a third of the time, something was missed. The answer was right there. The answer was right there, and it was just overlooked. It was overlooked on a pathology result that the patient had a diagnosis of microscopic colitis, which was the cause. It was overlooked that there was a pancreatic tumor, or it was not ordered. It was overlooked that the patient had something that really could have explained their symptoms, but it was overlooked and it wasn't treated. So getting a second set of eyes with a provider who's willing to take an hour and look through all your stuff and dig into the research and dig into your reports and pulling out some answers for you, or just even helping you understand, is worth it. And SIBO is the way we do some of this. So it's diagnosis like SIBO that help us get to root cause and understanding and helping our patients. So my goodness, it is 7:15, guys. I gotta go home. Have a wonderful evening. For those listening to this on the replay, enjoy it and hit me up with questions. Good night. Bye.